Doctor, we are live now, Doctor.
Very good evening to everyone. We have our Glaucoma Society India's Glauco Talks, a live webinar series. Today we have our Presidential Masterclass Series 2. We have our two very eminent personalities in India, the glaucoma specialists, and our past presidents. Dr. G. Chandrasekhar, our Vice Chair Emeritus from LBPI, Hyderabad. He is going to discuss on diagnosis of glaucoma, the appropriate use of technology. And we have our Professor Dr. Ramanjit Sigota from Shroff Eye Center. So we have two eminent speakers, and we have our panelists today, Dr. Surendra Singh Pandav, our past president of GSI, and Professor and Head, Advanced Eye Care Center, Chandigarh, PGH Chandigarh, and we have Dr. Sunita Dubey, Director Glaucoma Services from Shroff Eye Hospital, Delhi, and we have Dr. Sirisa Sendil, Head, VST Center for Glaucoma Care from LVP, Hyderabad. So without much delay, I would request Dr. Sirisa to introduce our past president, our beloved Dr. GC sir, for his first talk. Before the first talk, can you just introduce GC sir? Though we don't really require to introduce him, but as a customary, we'll introduce sir. Over to you.
Thank you, Dr. Satyan. So please allow me to share the slide. Yeah. So it's my pleasure to introduce my teacher, my guru and mentor, Dr. GC. So Dr. GC is one of the founding faculty of L.V. Prasad Eye Institute and possibly the only one who's continued in this institute over the past 37, 38 years now. And he's contributed immensely in building a strong foundation as well as evolving this institute as one of the most reputed institutions in the world. We all know that I think several of us in this country would agree that he's been our teacher who has possibly taught us the nuances of clinical evaluation and his training, whether it is the optic disc evaluation, whether it is the visual field interpretation and things like that. I think all of us are much better off only after we've been trained by him. So I can definitely say that because I have trained several other people, and whatever I am today, I think I owe it to him. He served as the president of Glaucoma Society of India in 2005 and 6, and has been a member of the prestigious Glaucoma Research Society since 2005. And he's also served as the governor of the World Glaucoma Association Board from 2013 to 2017. And he's been a visiting professor at the University of California, San Diego, University of Rochester in US. Another very important part which many people may not know, that he's built the education component not just for the ophthalmologists but also for all eye care professionals at LVPI over the past several years. And because of that, he's been the institution has named a chair in his name as G. Chandrasekhar, Chair of Director of Education. So whoever is the Director of Education at LVPI, his named chair goes to that person. He's also shared several other additional responsibilities, and he was our vice chair, and right now he is our vice chair emeritus, and he continues to be there helping us and guiding us. And to tell in a few words as to what Dr. Rao, the founding chairman of L.V. Prasad, calls GC as a clinician par excellence, a superb mentor and a teacher, an excellent clinician researcher with a sharp and analytical mind, and a thoughtful leader. I think every word suits him, and we welcome Dr. GC to deliver his lecture today.
Thank you, Shirisha, for the kind words. I hope my slides are visible.
Yes, sir, we can see your slides, sir.
Thank you. Thank you. So I'll get started. What I would like to do is talk about the diagnosis of glaucoma in the form of optic nerve damage, few thoughts on structure function correlation, and appropriate use of technology. Briefly about angle closure disease, some thoughts on how we use imaging for the diagnosis and understanding the pathogenesis. I'll conclude with a few words to say that as far as intraocular pressure measurement is concerned, Goldman continues to be the gold standard. So we diagnose glaucoma primarily by the changes that happen in the optic nerve head, the nerve fiber layer, and the visual fields. In that context, the World Glaucoma Association has given us the guideline that we need to have the structure function, function, or structure function correlation. If there is no correlation to make a diagnosis, we need to have a reproducible result. How does that translate to clinical practice is what I would like to highlight. If you look at this example, the imaging shows a superior nerve fiber layer defect, which is very gross. The visual field also shows a superior field defect that does not correlate. If you look at the optic nerve head and the retinal nerve fiber layer, unless you can convincingly, you're convinced that there is an anatomical change in the superior nerve fiber layer area, the imaging is wrong or the visual field is wrong. One of them is wrong, is what we need to remember. Just because there is a change in the OCT, we cannot make a diagnosis of glaucoma. Let me highlight that point with one more case. The visual field here is unreliable, but all the three Anderson's criteria, one of the three Anderson's criteria is satisfied because there is a cluster of inferior uh, pattern deviation probability plot more than 3. If you look at the optic nerve photograph, there seems to be a superior nerve fiber layer defect. Whether that superior nerve fiber layer defect actually correlates with very minimal statistical abnormality on the visual field or not is a dilemma. Then we go on to use the imaging. In the imaging, you see that there is a superior nerve fiber layer defect, superior neuroretinal rim loss, and that correlates also with the superior GCIPL loss on the macular imaging. So in the context of early diagnosis of glaucoma, in the structure correlation, the anatomical optic nerve head change and the anatomical OCT change are correlating with each other. With even a very minimal change in the optic visual field change, we can make a diagnosis of glaucoma. As I will show you subsequently, if the disease is advanced, we don't need an imaging technology to make the diagnosis. In early disease, to make a diagnosis of glaucoma based on OCT, we need to find the OCT abnormality specifically in the hemisphere in which we are suspecting the disease based on our clinical correlation, either of the visual field or of the clinical examination of the optic nerve. That's the fundamental most important point to remember, that the change in early glaucoma is usually limited to one hemisphere, and the imaging or the clinical examination and the visual field defect have to show consistent change in that particular hemisphere to make a diagnosis of glaucoma. If you're looking at how these technologies actually perform in a clinical research setting where that clinical correlation is not required, but you go by definite criteria, in this study, 93 normal, 26 ocular hypertensive, 67 established early glaucomas were put through all the three imaging technologies that are available at that time. What we see is that the area under the ROC curve, which is one of the diagnostic parameters that we use to compare different technologies, is very good. But to understand it to the correct level, what we need is to look at the specificity at 95% sensitivity, which essentially means that if you want to pick up the diagnosis more than 95% of the times, how many false positives are you kicking in? From this data, you can see that the number of false positives with the specificity is more than the specificity has to be more than 95%. The false positives tend to be as much as 70 to 60%. One more thing that you get from that study is that if all the three technologies, the scanning laser polarimetry, the OCT, and the HRT are picking up the neuroretinal rim and nerve fiber layer changes, only 19 of the 70 odd eyes correlate with each other. So we need to understand that we are not probably measuring with the technology what we actually need to measure. Looking at the more recent spectral domain OCT, if you look at the perimetric glaucoma with definite changes in the visual fields, though the area under the ROC curve looks very impressive but close to 90%, the sensitivity at 95% specificity falls down to 50 to 60%. In the context of thinking that we can pick up preperimetric glaucoma, this data shows what is its ability to pick up preperimetric glaucoma in the OCT by OCT. Once again, if you need to have high specificity, the sensitivity, the specificity falls down to 40 to 60%. That means that if you want to pick up 95% of glaucomas, you end up calling 40 to 60% of normals as glaucoma is what we need to remember. So in the clinical context, if you're correlating with the remaining clinical picture, you can avoid that difficulty. So to explain that concept a little more, I'm showing you here two examples of one OCT, one GDX. So the OCT is grossly abnormal and the GCT looks relatively normal unless you pay attention to the detail of the right eye showing some abnormality in the superpixel analysis. How does it correlate with the clinical picture? The abnormal OCT belongs to this optic nerve, which clinically one could probably say is normal. So this is a false positive sign, and this patient's visual fields have remained normal for the past 10 years. As opposed to that, if you look at this optic nerve with an inferior notch and an inferior nerve fiber layer defect, we don't need any imaging to make a diagnosis. We may need imaging to probably follow up. But if you look at the OCT here, this was the average parameters that were normal, but the specific change in the inferior nerve fiber layer defect that you see clinically here is what correlates with that. So what we need to remember is that these imaging technologies cannot be a substitute for poor clinical skills, but can complement a good clinical evaluation. This is an important editorial I would advise everybody to read carefully. And what it goes on to say is that devices cannot make our patients' conditions, diagnose our patients' conditions, but the findings they provide frequently alter the probability that the subject has a particular condition. What does it mean? It means that we need to clinically correlate. Going back by the earlier example that I showed you, if this disc looks clinically normal, even if your imaging technology is abnormal, the post-imaging technology likelihood of the patient having disease does not cross 50%. On the other hand, if this clinical condition shows that the patient has glaucoma, even if your OCT is negative, post-OCT, the probability of disease still continues to be more than 50%. That's what we need to remember. To highlight one more limitation or clinical detail that we need to remember with imaging technology, I'm showing you this example of a small optic nerve with a clear-cut inferior nerve fiber layer defect and notch and a classical superior arcuate scotoma. The imaging technology that we used at that time shows the neuroretinal rim to be completely normal. But if you go to the detail, the disc area in this patient is 1.5 millimeter square and the normative range is 1.7 to 2.8. That means this disc is small and is not included in the normative data of that imaging technology. And if you see the small print, it says Moorfield's regression classification, publication so-and-so, classification based on statistics, diagnosis is physician's responsibility. How do we do that? By clinical correlation. If the disc is so badly damaged with both superior and inferior notch, we don't need any imaging technology to make the diagnosis. The disease diagnosis is obvious. On the other hand, if there is a subtle nerve fiber layer defect superiorly and there is an inferior field defect, if you want to validate that, you can do the imaging. And in this structure function correlation, the imaging red and the black of the visual field are juxtaposed to say that this is signal and not noise. On the other hand, in this example, the disc is completely normal. The visual field is normal. There is a lot of abnormality in OCT. The important point to remember here is that you cannot call this as a preperimetric advanced glaucoma because the OCT is abnormal. you need to correlate what you're seeing clinically in the optic nerve and what is being shown in the visual field. That's the basic point I'm trying to make. One more example of how we use this clinically. The optic disc looks normal to me completely, and the visual field has a superior defect that is reproducible. I go back and look at the optic nerve. I cannot make out a neuroretinal rim damage inferiorly or a nerve fiber layer defect. Then I go on to do imaging technology. Though the averages are normal, there is a clear-cut inferior nerve fiber layer defect that correlates with the visual field that we have seen. That is how we use imaging and not just make a diagnosis of preperimetric glaucoma because of the red that you see on the OCT. One point about the visual field evaluation. This visual field is completely normal, but clinical examination as well as the OCT shows an inferior nerve fiber layer loss and GCIPL loss on the imaging. Before calling this as a preperimetric glaucoma, we need to do a 10-2. That is the appropriate use of technology. That shows a very marked visual field defect in the superior hemisphere. One detail that we need to remember is that the susceptible area of the neuroretinal rim or the nerve fiber layer superiorly actually is beyond the central 10-2 visual field area. But inferiorly, it involves the central 10-2 visual field area. So whenever you are suspecting damage in the inferior neuroretinal rim, it is mandatory that we do 10-2 before we call it as a preperimetric glaucoma. Moving on, talking about the angle closure disease, as far as diagnosis is concerned, we need to remember that resolution that you get with imaging technology is at the cost of field of view. What do I mean? Clinically, we need to differentiate between primary angle closure suspect and primary angle closure because primary angle closure mandates an iridotomy and primary angle closure suspects can be followed up. And for this, we definitely need a gonioscopy, and the imaging cannot substitute gonioscopy. While the imaging technology looks very nice to look at the trabecular meshwork, the scleral spur, and the narrow angle, the iridotomy, or even the goniotomy cleft that you see following the opening of the Schlemm's canal with your surgery, what you need to remember is that, one more point, the detail of clinical research that can be possible with the imaging technology, what we need to remember is that in the gonioscopy, we are not only looking at whether the angle is occludable or not, but we are also looking at a lot of changes within the angle. So those changes within the angle are the ones that establish the diagnosis of primary angle closure. So this gonioscopy shows an occludable angle. On indentation, you see these blotchy pigments. These blotchy pigments are the ones that will differentiate between a primary angle closure suspect and a primary angle closure that cannot be made out by your imaging technology. By virtue of their high resolution, they cannot pick up this detail or the broad field of view. One more example of an occludable angle with on indentation showing a superior synechia and a blotchy pigment that is diagnostic of primary angle closure. Couple of more advantages of indentation gonioscopy. Peripheral bulges on the iris on gonioscopy without indentation will look like synechia, but on indentation they will disappear. So this is something that is possible only with indentation gonioscopy. One more example of a use of indentation gonioscopy, a closed angle opening an indentation with a hemispherical bulge that translates to a ciliary body cyst. So a gonioscopy in the clinical skill, if once develops, is as good as a UBM in your pocket, in certain situations at least. Going on to talking about the understanding the pathogenesis, trying to differentiate between the correlational risk factors versus what actually causes the disease. With the advent of optical coherence tomography, a number of parameters can be measured, and there is a lot of literature that tries to classify the disease based on these risk parameters. So this is one of the studies that shows that of the 6 parameters that you can pick up with anti-segment OCT by measuring, and if you want to classify, pick up angle closure disease from angle closure suspect or normal angles, the area under the ROC curve looks very impressive, more than 0.95. Because of that, the authors go on to conclude that a classification algorithm based on stepwise logistic regression that used a combination of 6 parameters obtained from a single horizontal ASOCT identified subjects with gonioscopic angle closure in 95% of the time. But if you look at the detail, while they get a sensitivity of 95%, their specificity falls down to 70 to 85%. That means that if you are picking up this angle closure with that ASOCT, you are calling 15 to 20% of normals as having angle closure disease. So we need to not just look at the ASOCT, but specifically ask for what is the specificity at that high sensitivity if you don't want to wrongly overlabel the normals as having disease. So most of these causal associations, the statistical methods are not actually pathogenetically causal. Statistical methods cannot establish proof of a causal relationship in an association. Causal significance of an association is a matter of judgment. What do we mean by that? We have the narrow angle, the lens vault, the iris thickness, the ciliary body position, all anatomical factors that can predispose to an eye to angle closure. Based on these anatomical factors, if you want to see the number of eyes that have these anatomical factors that go on to develop from primary angle closure suspect to primary angle closure, 2.61% to 1%, and primary angle closure to primary angle closure glaucoma only 0.3%. This is a prospective study from Chennai glaucoma study data. So what we need to understand, pay little attention here, is that all these anatomical factors in various combinations can produce the disease. Which of these anatomical factor is mandatory in all the causes is called a necessary cause. All the remaining ones become contributory causes. A combination of these contributing causes will cause the actual disease. In these anatomical classification, unfortunately, we are not looking at the dynamic factors that are responsible for angle closure. And this is what is highlighted by this Jackson Memorial Lecture by Harry Quigley. So the iris and choroidal volume changes that are dependent upon the autonomic changes that predispose to angle closure is something that we don't know. Without knowing that, based on the anatomy that we see, we go on devising different surgical procedure to take care of the disease, which I think is inappropriate. So towards the conclusion, I will share a few thoughts about intraocular pressure and glaucoma. The true intraocular pressure in an eye can be measured only by manometry, is what we need to remember. The Goldman applanation tonometer that was devised in 1954 continues to be the gold standard. There are limitations and errors in the Goldman measurement that we need to be clinically aware of. We all know that the corneal thickness affects the applanation tonometry, but what we need to remember is that the corneal thickness that we are looking at is not the population normal corneal thickness, but the corneal thickness that is used for GAT calibration, which is 520 microns. There is only, I think, this study that correlates the intraocular pressure variation with the corneal thickness. Though we take that 70 microns, change is approximately equal to 5 millimeters of mercury. At lower corneal thickness, it can vary from 4.2 to 6.2. At higher corneal thickness, it can vary from 4 to 4.5. That's what we need to remember. The important point that I want to make is that non-contact tonometry, as comfortable, as convenient as it is, cannot be used for either diagnosing or following up patients of glaucoma. Because the pressure measurement is done in 1/500th of a cardiac cycle, the measurement variation is huge. And that's the reason we cannot use it for either diagnosis or for monitoring. While there are so many new technologies that are coming up as far as intraocular pressure measurement is concerned, when we evaluate these intraocular pressure measurement technologies, what we need to remember is that we are not correlating the intraocular pressure measurement with the new technique with the gold standard. What we need to look at is the agreement. And what do we mean by that agreement? With iCare Pro and the applanation tonometer. The average difference between them is only 0.3, but the 95% confidence intervals of the measurement difference between the two instruments can vary anywhere from plus 6.2 to minus 6.8. Is that what you want to use in place of a Goldman appellation tonometer in adult population to make decisions on diagnosis and management is something to think about. So to summarize, I talked about structure function correlation, and we need to use the clinical skills and understand the concept of prior probability. In the context of imaging technologies in diagnosis of primary angle closure disease, resolution is very good to look at, but it's at the cost of field of view that differentiates primary angle closure suspect from primary angle closure. As far as pathogenesis is concerned and the new various treatment algorithms that we want to develop, we need to differentiate between correlation and causality. Intraocular pressure measurement, the latest is not necessarily the best. So to conclude, it's the new technology is not a substitute for poor clinical skills, but a complement to a good clinical evaluation. I will conclude with this quote from an article called Hyposcylia. While modern medical technology has enhanced our ability to diagnose and treat disease, it has also promoted laziness, especially mental laziness, which prevents physicians from using the most sophisticated, intricate machine they will ever and always have, the brain. Thank you for your attention.
Thank you, Dr. GC. That was a wonderful overview. Yeah. So we will move on to the next presentation, and then Sunita will introduce Dr. Ramanjit. So we will have questions maybe at the end of both the talks. Thank you.
Thank you, Dr. Satyan and Sirisha. So can I share my screen?
Yes, yes, please. Make it as a full page. Yeah.
Yeah, so it is both a privilege and honor to introduce Professor Sihuta. She is a stalwart in the field of glaucoma with over 4 decades of experience in clinical practice, research, and education. She headed the glaucoma research facility and clinical services at RP Center, AIMS, New Delhi for 14 years, and she is currently a consultant at Shroff Eye Center, New Delhi. She completed her MD in ophthalmology in 1982 and her FRCS in Edinburgh in 1984. She won the World Glaucoma Association's Research Recognition Award in 2011 and numerous national and international awards for her research in glaucoma, especially primary angle closure disease, glaucoma surgery, and imaging in glaucoma. She has spearheaded the National Glaucoma Task Force, which is currently operational across India. And she has also taken the lead in rationalizing the treatment of primary angle closure disease in Southeast Asia. She extensively revised Parsons' disease of eye and has written chapters in books and published over 200 international papers in indexed journals. She is a member of International Glaucoma Research Society, National Task Force in Glaucoma, the Glaucoma Advisory Group and Project Evaluation Committee of ICMR, the Postgraduate Committee of Medical Council of India, the Executive Committee of Glaucoma Research Society, Asia Pacific Glaucoma Society, and committees of the World Glaucoma Association. She is a past president of Glaucoma Society of India, and she has been an invited speaker at various societies, the International Glaucoma Research Society, Association of International Glaucoma Societies, World Glaucoma Congress, Moorfield Glaucoma Symposia, Southeast Asia Glaucoma Interest Group, Asia Pacific Academy of Ophthalmology, Asia Pacific Glaucoma Society, and All India Glaucoma Society. So she has made significant contributions to the understanding of glaucoma and continues to shape the field through her leadership and research. So we eagerly look forward to her talk on long-term prognosis of glaucoma. Ma'am, please.
Thank you very much. should I share my? Uh, I think between GC and I, we have enough white hair and many years to to tell you what possibly is useful in the management of glaucoma. And I'm going to talk to you about glaucoma prognosis today. So, if I was diagnosed with glaucoma, say 30 years ago, I think I would have liked to know what was I likely to see 30 years down the line. So, just a short sort of overview of what we actually know about the prognosis. And even the last decade, you can see these two publications, 2014 and 16, were they were very good in the sense they said, okay, better than the previous 20 years, we have done better, but still 15% of the patients went on to blindness when you look at the Olmsted County. And in another study which said that in 20 years after the glaucoma diagnosis, 1 in 3 people are unilaterally blind and 1 in 7 are bilaterally blind despite treatment. So it makes you stop and think, is that actually something that we want? So from India, you can see the publication in 2022, which said that over 20 years, the prevalence of blindness for PACG was about a quarter. For PAG was between 11 and 10%. We look at more recent reviews. Okay, so over 4 years, and the UK prospective cohort over 20 years. And they still give you a 5.5% risk of blindness with a median time after blindness to death of 16 years. They said over these 20 years, 2/3 of the eyes continued to progress by at least 2 visual field grades that they used. So obviously there is something that is not quite right. And we go back to the landmark studies. And the moment you start looking at, those that were long, so you can see the Oath study at 20 years telling us that 50% of the eyes which had ocular hypertension had progressed. Of course, they broke it down and said the lower the risk, the less the likelihood, the higher the risk, almost 60% progressed. Again, when we look at what was said by the EMGT study, again in 21 years, they said there was visual impairment in at least 20%. If we go down, we have a collaborative initial glaucoma study which said 25% either medical therapy or surgical therapy did continue to progress. But what was actually heartening was that in the severe glaucomas, advanced glaucoma study, they said that yes, there was progression, but it was significantly less after a trabeculectomy. That is, the newer trabeculectomies with fewer complications was actually done. So if we sort of go on from there, could we actually transpose what is seen in the landmark studies to what we see today? I think we have to be very aware that we are fairly different as far as the glaucomas we see. We are different in the way our eyes are made. So while Indian corneas are about 525, the mean CCT for Caucasians is 540 plus or minus 30. You can see that the intraocular pressure at diagnosis in the EMGT, 80% of them was less than 25, while most of our glaucomas are 24 to 32 millimeters of mercury. The mean age for Caucasians at diagnosis is 60 plus. For us, it's 40 plus. So when they make a diagnosis, the life after diagnosis is probably 9 to 13 years. And if they do surgery like trabeculectomies, they are hoping that it lasts for 7.5 years. What about us? We are looking at patients who come to us at 40 and are now living up to 90 plus years. And even the average life expectancy tells us that probably we have to look after them for 30 years. So again, just to reiterate, it comes earlier, there's a longer duration. We see greater severity at presentation. We have many more angle closures in secondary glaucomas. The economics, the ubiquitous steroid use, the lack of awareness, all makes life very difficult for us. And these are the very factors that have been identified in all the landmark studies to say that they are the high risk factors for progression. This was a study we did many, many years ago, and it quickly told us that if we followed what the Caucasians were telling us, that less than 20 is very good even in the early glaucomas, less than 18 is very good for the moderate glaucomas, these were the patients we actually saw progressing. The other thing we noticed was the intervisit fluctuation. So if you find a patient who comes to you on medication with a pressure of 12 one day, 2 or 3 months, comes back for the next visit with a pressure of 70, it's a warning sign that either the compliance is poor or the medications are not working, but something in this is not going quite well. So from that, we decided that possibly for us, keeping in mind the thinner CCTs, all the problems that we've already elucidated, that these Canadian guidelines or even the guidelines that the Americans are following at the moment probably don't suit us, and we need to have lower IOPs, less than 17, less than 15, and less than 12. So we have learned some lessons, and the whole aim is to maintain visual function and quality of life at a sustainable cost. We've learned about the natural history. We know lowering IOP sufficiently does delay or stabilize visual field progression. We know quality of life is affected at every stage of glaucoma. Prevention of glaucoma is a possibility today. Target IOP appropriate to visual field damage does seem to work. And many risk factors have been identified that we can actually use in targeting and making the medication that we use more personalized. I think GC has already spoken to us about the diagnostics, and all I would say is that when you're looking for progression, when you're following patients up over time, remember that the initial damage is the point at which you're going to focus, because whatever's going to happen, whether it's on a imaging, whether it's on fields or anything else, is at the edge of the previous loss or a deepening of the previous loss. So now when we look at each kind of the primary glaucomas that we are more likely to see, I think we've learned quite a lot. And though a lot of people are saying the ZAP study hasn't shown us very much, I beg to differ and say that at 14-year follow-up, what they actually showed was a 66% decrease in the progression to PAC after an LPI. Also, most necessary was the fact that it has also shown us that the LPI was safe. There is no need to worry about that. And finally, the risk factors that you would consider in a patient with a primary angle closure suspect, beyond the usual ones that we talk about, distance from an urban center, family history, was that central and peripheral shallow ACs or a higher IOP, either baseline or on follow-up, was an indication for you to actually think that these patients may progress. So please follow those up closely and prevent this from getting into a neuropathy. The OAK study in the long term, 20 years, again said 30% of them developed POAG in one or both eyes. These were the risk factors that the chance of progression in 20 years. We've already spoken about it. And the risk factors. I think if you look at it, this is something that we keep using all the time in daily life. Age, the older age are more likely to have problems, thinner CCT more likely to have problems, a raised IOP beyond your target, if they start off with larger baseline damage, and if they have a family history of people going blind, these are the patients that you're actually going to be worried about. Now, cut back to India. We did do a study on ocular hypertension, both open angle and PSC, to see what was the difference and what was actually the risk factors that caused progression. We followed them up for about 9 years. In open angle eyes, the progression over this period was 13%. In primary angle closure with ocular hypertension, it was almost 20%, even though the IOPs remained pretty much the same. So risk factors for both were if you needed more than 2 drugs to bring the pressure below 18, which was what we had set as target, which means that they were actually having a higher baseline IOP. If they had coronary artery disease or had used steroids, chronic steroids for any use. In primary angle closure eyes, if they had a very small disc area, that seemed to be another risk factor as well. In POAG, again, over 10 years, what we followed patients up, we found that only about 11% were found to progress, and that also only by a few loci. Most of them were 3, and only 4 eyes had more than 4 loci that actually changed. 30% of them needed trabeculectomy, so keep in mind that surgery in our eyes may be something that we require more often than the Caucasians do. What about this whole talk about primary angle closure and mild or early primary angle closure glaucoma with lens extraction? So the EAGLE study told us that the IOP difference between iridotomy and clear lens extraction was 1.18. The authors themselves said not clinically significant, but nowhere in that publication do they talk about progression. 3 years of follow-up, no talk of progression. So another study which was done again for 3 years looked at the same lot of patients, PACG, early PACG, and showed that almost 2/3 showed structural progression after the clear lens extraction, and 1/3 showed visual field progression. And they said that thinner preoperative RNFL and higher postoperative IOP fluctuations were possibly the risk factors for people who have had a clear lens extraction or a cataract extraction in patients with PAC, PACG. Again, many other studies have now been done. We have many studies which are telling us which PACIs are likely to progress. Those who develop ocular hypertension, those who have a thicker lens, narrower angle, those who show us more than 2 quadrants of pass at baseline. So all these again are risk factors in primary angle closure eyes, where we are going to be much more careful and treat them, lower the IOP much more adequately. What about acute primary angle closure? We are now able to control pressures, but there's still a such significant amount of glaucomatous optic neuropathy as compared to the fellow eye. And this study has actually shown us that despite an iridotomy in the fellow eye, 50% still develop chronic angle closure. So be very wary of such eyes and keep looking at the fellow eye as well. What about primary angle closure glaucoma? We looked at over 300 eyes with mild, moderate, and severe glaucoma, looking at keeping our target pressures to what we had decided was best for the Indian eye, less than 18 in mild, less than 15 for moderate, and less than 12 for severe. And we were able to actually have a progression of only about 2% at the end of 10 years. Most patients in the mild group we were able to control medically. Most patients in the surgical group needed a trabeculectomy. So do not hesitate to do a trabeculectomy or a surgery early in Indian eyes. Severe glaucoma. This study again of over 5 years has shown us that 1/3 of patients, and more importantly, almost 20% of fellow eyes had a significant visual field progression. And this was again that, there was a problem with lower ocular perfusion pressure in most of these eyes. And 6% of them during these 10 years, 6% became bilaterally blind. So again, be careful. Severe glaucomas less than 12, keeping in mind CCT maybe even 10 or 8. Normal tension glaucoma is the other one that we talk about frequently, and I think 30% of them in all studies, or whichever study you look at, they say 30% of them progress. And those who are more likely to progress are those who have disc hemorrhages, those who have a lower diastolic BP and higher diurnal IOP fluctuations. So to my mind, have a target range for a target IOP is probably better than just a number or percentage lowering. Achieving target IOP in India is somewhat different from what you've been described in the landmark studies or in textbooks. We do need an iridotomy in all PACD, PAC, PACG, definitely need an iridotomy. Pilocarpine works very well for us, either on its own or as a combination with timolol. Early trabeculectomy has been shown to be long lasting in all studies. So since I'm talking about long-term prognosis, I'm not going to go into MIGS, I'm not going to go into anything else, but all I'm saying is try and get your target IOP done, even if you have to use, as I have used in certain patients, almost 6 medications in various combinations to get to that target IOP. So finally, what can we do to improve the long-term prognosis in India? One is, remember, we are slightly different from whatever you read in books. Baseline severity of glaucoma and the rate of change in the first couple of years will actually determine how much these things are going to progress. So be able to pick up, diagnose that progression at the earliest. So you hope to diagnose them early. You use all the things that Dr. GC has told us. Screen relatives, catch them early. Do an iridotomy, as I said, for all PACGs, lower the individual target IOP from what has been described in most of the landmark studies. Do an early surgery, because for us, it's a medication sometimes are not available, not affordable, and we need to reassess target IOPs over time. But does that mean we've solved the problem? No, I think there are many, many questions that remain. And to my mind, the question is prevention better? Should we be treating all ocular hypertensive? Should we be treating every PACS that looks, slightly high risk with an iridotomy? Second is, what is the best target IOP? I think this is something that we came up with in RPC over time. Is it easy to control progressing eyes? That's the other question, that, you have 100 patients and you'll find that, 40 of them are stable and doing really well. You've achieved your target IOP and everything else. And there'll be like 10%, 15% who will continue to progress regardless of what you're doing. So at that point, you say, should I have done something before to prevent them from progressing, or is this something that, was inherently there? And finally, progression and glaucoma sort of changes over time. Are they linear? I don't think so. I think whatever we've seen over time, you'll find that they do well for what, 6, 7 years, and then suddenly one day they'll come back and the pressures will be 28 and 30, and the field will start showing you problems. Possibly related to whatever else they're using. And I think, to my mind, in India, steroid use is my bane. Almost every second patient has been on steroids for something or the other, despite writing on their prescription, avoid steroids. So I think we have many things that we still need to answer. I think we have improved management. GC and I come from a time where we had pilocarpine and epinephrine and we had nothing else. So I think we are now blessed with so many medications. We are blessed with surgeries that have become much safer. So I think it's a question of deciding when to use them, to what target IOP we want to achieve, and trying to educate our patients to actually use the medications properly. Thank you.
Thank you, madam. And sir, GC sir, it is such an eye-opener for most of us. Though we all learn every bit, small things we keep on learning in practice. So thank you so much, GC sir and Ramanjit madam. And I would request our panelists, Dr. Pandav, Dr. Sirisha, and Dr. Sunita to discuss. Over to you.
Thank you, Satyan. I think that we had two really wonderful lectures. I think in a very short time, I think both the talks are very well. I think very precise in their topics. I think the GC covered the diagnostics part. And as he mentioned the hyposcalia. I think that actually kind of lets me thinking that's actually really a problem. And we are relying more on technology. And, that means kind of people tend to think that, the lack of clinical skills can be compensated by technology. But I think he has a very aptly and very strongly put across that point that I think that's really not the case. And the basic clinical skills are still required, and that's kind of fundamental to the practice of ophthalmology and glaucoma. So that's true for all specialties, actually, not only glaucoma, but particularly for glaucoma, because here the disease is not obvious. You have to look for it, because most of the time there's an asymptomatic disease, and the patient, they don't know that they have the disease, and also the doctors don't know if the patient has the disease unless he or she looks for it. So I think it is very effort is required to get to that point where you can start suspecting that the patient might have a disease, glaucoma, and then subsequently prove or disprove it. Dr. GC, you have covered most of the technologies. I was just wondering what will your view on the OCTA, because nowadays people have started coming with, a lot of people come with OCTs, and now I've started seeing patients with OCTAs as well. So how do you view OCTA as one of the diagnostic things for the glaucoma?
I don't think it has any role in the diagnosis of the disease. It may have a role in understanding the pathogenesis of what is happening with the choroidal circulation and things like that, though the choroidal circulation doesn't show up that well in OCT angiography as the retinal circulation. I think OCT angiography and OCT are a big addition boon for the retina community. As far as glaucoma community is concerned, we are trying to find a use for them, having invested in them. As far as diagnosis and management is concerned, we need to realize that majority of our patients cannot afford, or whichever background they are from, like Ramanjit pointed out, we need to have the clinical skills. I don't think OCT angiography is a tool that is required for glaucoma diagnosis or management.
I think, and
But
also,
OCTA probably has a role in a small sort of segment when we are talking about, disc suspects or pre-parametric glaucoma. Sometimes, you're sort of debating, should we treat, should we not treat? Maybe once we have these long-term data from the OCTA, these disc suspects, we probably will be able to have a little bit more sort of objectivity in saying yes, treat or no treat.
Because most of the
Can
studies.
I?
Go ahead,
Yeah, I
Sunita.
have. Yes, sir. Please.
No, go ahead, Sunita. Go ahead.
No, just a question because I have done OCT angiography in some of the normal tension glaucoma patients. So since it uses motion detection, so it greatly gets affected by the motion artifacts, like even the saccadic movements and blinking of the eye affects the values. I have seen in some patients, and the values vary a lot. So I don't know, like, what are your observations, ma'am and sir? Because you can't rely unless even the signal strength, if it is 9 and 10, if it is less than 8, then it doesn't, the values are not reliable at all. So what is your observation?
We've just done a study looking at, patients who were normal, patients who were ocular hypertensive, disc suspects, and those who had a nasal step, a very definite glaucomatous nasal step. So there was some sort of very significant statistical difference. Now, whether it will translate into diagnostic is something I think we still have to wait and see. But I thought for this small segment where, you're saying, shall I treat this disc suspect? There are some risk factors, there isn't very much, shall I do it or not? So maybe it might help us in those situations. But statistically, there was a very significant difference between these groups.
Yeah, and if I just can add a point, while these newer diagnostic tools and all of these are very important, and while we are discussing about whether we'll treat a risk suspect or not,
Okay.
one of the biggest problems that we face on a daily basis, and even today I had somebody who's a ophthalmologist, who's a glaucoma specialist, and who's been scared to death that there is glaucoma because your disc is progressing, your OCT may be normal, your visual fields may be normal, but things are not okay, so start on treatment. So I think the first and foremost thing that we need to understand and emphasize, and maybe, I don't know, we can tell it 100 times, is that learn to do a basic evaluation of the optic disc and then add all of these things to it. Because if clinically we are almost sure that this is normal, then I think any artifact that any change that you see on any of these devices, we know that they are artifacts. Having said that, there may be a small cohort of patients. I agree that what Dr. Ramanjit was saying, in those really suspicious eyes where you don't know whether this is glaucoma, no glaucoma, family history of glaucoma is there, you want to treat or not to treat. So that is a small cohort of patients. And I think even if we don't treat them and we're going to follow them up very closely, we still will be able to pick up an early disease. But unnecessarily scaring people to death by unnecessary investigations, and you see a small couple of red dots there, and then you want to treat them with the toxic anti-glaucoma medications for the rest of their life when they don't have a disease, I think is the biggest problem that we are facing today. So missing out obvious glaucomas, picking up no glaucomas and trying to treat them, I think is a big problem, and we should emphasize this and maybe use the technology to the best of its ability. But ultimately, we need to, the doctor needs to use the judgment.
Can I say something like this, Risha? Like whenever you see the patient in clinical examination with a 90D, we can correlate with a fundus photograph, a good fundus photograph. It gives us a lot of information than just only a 90D with the small people. And then go on doing your OCT or visual fields, and then see the disc and try to correlate all the areas. Now we can really look at the you put the fundus photograph in your desktop, not as a printout. Put it in the desktop and you can magnify and see every RNFL so clearly. And then correlating your either OCT or the visual fields. That seems to be a better idea than just looking at only OCT and then trying to come to some conclusion saying that, okay, the patient has a disease or not having a disease. So GC sir and madam, you can just add your inputs over that. Comparison of, all the technologies, not only just in isolation that you come to some conclusion.
I think I said that I agree with you that a disc photograph is superior to a clinical examination. That I agree, because of the patient cooperation, the light sensitivity and things like that, documenting a disc photograph. My only point is going by only OCT and calling them as preperimetric glaucomas when they're actually artifacts, myopes, or whatever else it is, I think is unjustified. That's the only point I'm making.
Yes, sir. The next thing, what we routinely see is normal disc, the so-called normal appearing disc without much of a PPA. Then probably the OCT gives you a reasonable amount of outcomes. But if the disc is little abnormal in size or having a lot of PPA like myopic discs, then the problem is if you just do the OCT, the OCT, all the OCTs use their AI platforms. It is not drawing the disk margin or whatever the other adjacent areas. So the outcomes are going to be completely different. So we are really not seeing, when we are doing the OCT, we are not seeing the complete profile of the patient. We just see only the printouts. So that gives us a lot of misinformation, whether it is a disease or not disease. So that is a concern that we often see in our routine clinical practice. So it is better we see properly whether the disc margins have been drawn properly or ILM has been drawn properly. Everything is been drawn properly. Otherwise, it is going to be, again, a lot of errors.
I
Yeah.
think this.
Sorry. Please go ahead, Dr. Pandey.
Please go on, Sirisha. Please go on.
I had a question to Dr. Ramanjit. So while you very beautifully explained how different our Indian eyes are in POAG, PACG, as well as NTG, I wanted to ask you about juvenile open-angle glaucoma. This is an area where all of us struggle, and then this disease is not easy to treat. So would you treat these eyes slightly differently compared to POAGs or an NTG?
Yes, I think first, as Indians, we tend to see many more juvenile glaucomas than I think any other country sees, or at least in the Caucasians. And for some reason, we are also getting a lot of pigment dispersion sort of syndromes very commonly, which again is fairly rare outside. So, as far as the treatment of these is concerned, I think I would be a very sort of aggressive as far as surgery is concerned. But the question is, get a surgery that's going to last. They come to you when they're sort of 16, 18, 20 years old. How long is the surgery going to last? So all I can say is that I have seen patients now for over 30 years. Some of them still follow up with me. So you do need to add medications, because trabeculectomy in these eyes, especially when there was no mitomycin, was quite a poor sort of success. With mitomycin, we got more success, but we also got a few complications that, they would tended to get hypotonic maculopathy, hypotony, and things like that. But I think overall, I would be more aggressive in surgery in such patients, because for them to put medication, they're not compliant. They don't sort of come back regularly for a follow-up. Medications don't reduce the IOP very frequently to the target that you want. So surgery probably for me would be a much earlier option than in POAG.
Yeah, thank you. And I think we all agree with the fact that these are very aggressive glaucomas. Sometimes we see people losing eyes in few months' time, and the pressures are very, very high and they're fluctuating. So there are multiple reasons why, and of course, the young people, non-compliance, a lot of those issues that we need to worry about as well. So JOAG is a different problem altogether, and possibly all of us need to be a little bit more aggressive. And also the family, while we know that when there is a family history of glaucoma, so we always ask, did your mom have a disease, or a dad have, or in the family, the senior members in the family, if they've had it. Actually, this is the other way around. When we diagnose somebody with JOAG, When you ask
Yeah.
their family history of glaucoma, most of them say no. And now when you actually tell them that your parents or grandparents, if they are alive, we need to test them, you figure out one or two of them in that family, at the immediate family, may have glaucoma too. So I think that's again very important. Family screening, especially in these patients, becomes very important.
I mean, when we were talking the diagnosis and the performance of these tests, I mean, one thing is that, all these tests, they probably are good for certain discs. I mean, what we can say is a normal disc. I mean, what is a normal disc? The definition itself, could be variable. But the thing is that there are as many kind of discs as many people there. So there's so much of anatomical variation. I think these it's kind of not possible to calibrate all these machines to all kind of discs, and I think that probably is one of the reasons that these tests don't perform uniformly good in detecting glaucoma from normals. So I think that and that will remain because because the phenotypes are very different. The normal the disc appearances are very different. The normal anatomy is very different, very variable. So I think that would remain as a factor in making
So,
errors.
I think that, we
Other
still,
thing I
all
was
of
coming
us
to mind
use
is
visual fields, perimetry as the gold standard, both for diagnosis as well as for progression. We may do the OCT, we may do the OCTAs and whatever else, but at the end of the day, it's the visual field that actually um, helps us in ascertaining, where do we want our target IOP to be? How soon do we want to see the patient? When do we want the fields to be repeated? Because OCT is still, as has everybody has pointed out, is something that is variable. There's too much individual variability for us to be able to pick up one OCT and say that only on the basis of this I'm going to manage the patient.
Ma'am, I have one question. As you mentioned in your talk, and we know that there's a lot of variability in the rate of progression. So, what are the red flags which prompts you to ask the patient to come for very frequent follow-up? Are there any special risk factors? We know about the risk factors, but in your practice, like what is your experience about calling the patients? Because some
I
of the
think
patients are from out of station, and when they come for the next visit, they have already progressed. So,
yes, yes. So I think that, one is try sticking very, very strongly to those target IOPs that I have put up. The second is that, beyond these target IOPs, as I said, the age of the patient and the comorbidities, specifically all the cardiac comorbidities, are the ones that we need to watch out for. We also need to watch out for these thin CCTs. We start off at 520, but you'll find that a lot of patients who are progressing are those who have 450, 480, 470 CCTs. So I think that needs to come into the equation as well when we are thinking in terms of how frequently we follow patients up. And finally, if you have a patient who says I am asthmatic and I can't get off my steroids, these are the three red flags. I would say come back every 2 months if you can, come back at least once in 3 months. And I would also probably do the perimetry a little bit more frequently for these three flags. There must be more, Dr. GC, any more red flags?
I think one thing we are finding of late in people progressing with glaucoma is the sleep apnea. With
Ah,
normal IOPs, we are finding sleep apnea to be quite, they come with AHIs of 30s, 40s, 50s. So that's the other thing that.
I also think this has now become it's like in the old days, everybody started coming with OCTs. Now everybody comes to you with a sleep apnea study as well.
Google.
Yeah.
So,
No harm.
thank you. Yeah. Thank you so much, GC sir and Ramanjit madam, and all the panelists for your wonderful guiding us for understanding about all this IOP and the diagnostics. We know that we can keep on discussing on this particular topic, but unfortunately, we have to close this session for today. And thank you all once again. I just wanted to share one thing for the next meeting. Sorry, one second. Yes. I think we have some problem. Okay. So the next meeting is on 25th of February. That is on KDB and the newer drug delivery systems by Dr. Kaguk Malik on 25th evening, 8 to 9. So thank you all once again and good night.
Thank you.
Thank
Thank
you.
you, sir.
Thank you very
Thank
much. It was lovely to see everybody.
Thank you. Yeah.
Same here. Thank you so much.
Good night.
Bye.
Good night.